Since the publication of the 1995 NINDS trials on the use of intravenous alteplase for acute ischemic stroke, recombinant tissue plasminogen activator, or TPA, has been a standard of care for the acute treatment of cerebral infarction. In 1996, the FDA approved its use for acute ischemic stroke with certain restrictions. It would be an understatement to say that TPA revolutionized stroke care. The recanalization rate of large vessel occlusion after TPA may be as high as 20%, according to some data. A low number, but a 1 in 5 chance of restoring blood flow to dying brain tissue. That's versus practically 0% if you did nothing. But it comes at a cost. A risk of symptomatic intracerebral hemorrhage, which we see in 2 to 5% of patients who get IV TPA. Still, we give TPA because the benefit vastly outweighs the risk for most patients. The question I'll be raising today is not a question of, is TPA good enough? The question is there something out there that's better? Well, over the last decade, a number of groups have sought to answer this question, and their efforts will be the subject of our program today. Welcome back to Brainwaves, I'm Jim Sigler. Today on the show, is another drug taking over TPA? Stay with us. Today's episode is part of the mini-series within our program which I've called Quanta. As a reminder, this refers to the small, discrete amount of neurotransmitter that's released from a single vesicle in a neural synapse. Very small amount of information. And these shows are intended to be very brief, so I'm only going to touch on the highlights. Let's get started. Tenecteplase is a third-generation, 3-point mutated, bioengineered variant of alteplase, super TPA. It was designed and proven to break down the fibrin clot within a thrombus, to have a higher specificity for fibrin, to have a longer half-life, and to be more resistant to breakdown by plasminogen activator inhibitor 1 than standard alteplase. In cellular and non-human animal models, tenecteplase, or TNK, was superior to alteplase for achieving thrombolysis in a variety of settings, but this is old news from back in the 1990s. For a drug to enter the standard clinical pharmacopoeia, we need to prove safety and efficacy in humans. The ASCENT-2 trialists did this in 1999 with myocardial infarction, and now TNK is the preferred agent in acute MI. Among its other benefits, TNK carries a lower risk of systemic hemorrhagic complications, and it can be delivered in a single bolus rather than a 1-hour infusion for alteplase. Most of you probably don't even think about this when you're treating a stroke patient, but especially in the age of endovascular thrombectomy, delays in transfer of patients because you have to hang TPA, maintain a dedicated peripheral IV, and monitor for reactions to TPA. Being able to give a single push of a medication is a huge benefit for TNK over alteplase. It's just easier. But is it safe in acute ischemic stroke? The answer to that question is going to be yes, and here's why. The tenecteplase and stroke investigators conducted a dose escalation trial which ended prematurely due to slow enrollment in 2008. The investigators randomized patients to IV alteplase, TPA, or tenecteplase, and if they were randomized to tenecteplase, the patient was further randomized to receive 0.1 mg per kilogram, 0.25 mg per kilogram, or 0.4 mg per kilogram of TNK. 16% of patients who received the 0.4 mg per kilogram dose experienced a symptomatic intracerebral hemorrhage, which was defined as a confluent hemorrhage associated with neurologic worsening that persisted for longer than 8 hours, whereas only 7% of patients had symptomatic ICH in the 0.25 mg per kilogram group and only 3% in the TPA arm. Overall rates of intracerebral hemorrhage were also higher in the 0.4 mg per kilogram dose group, 26% versus 13% in the 0.25 mg per kilogram arm, 10% in the 0.1 mg per kilogram arm, and 16% for TPA. A follow-up Phase 2b trial was then conducted and randomized patients to either the low-dose or the medium-dose TNK or alteplase. In this trial by Parsons and colleagues, patients were treated up to 6 hours after symptom onset. All patients were reasonably matched for age and comorbidities, and to be included in the trial they had to have good premorbid function and no prior stroke. The stroke being treated must have been clinically significant. Patients were included only if they had a baseline stroke scale score greater than 4, and they had to have had an intracranial large vessel occlusion and a penumbra volume of at least 20 cc's on perfusion-weighted imaging. The average age of the cohort was about 70 and an average stroke scale score of 14 to 15, so moderate to severe deficits. Initial infarct core volumes were about 10 cc's, and the penumbra volumes were 75 to 80 cc's, all basically the same between the treatment arms. In TNK-treated arms, there was a non-significant but lower risk of symptomatic ICH, 4% versus 12%. The incidence of any parenchymal hematoma and death was also no different between TNK and TPA. So at least in this small Phase 2b trial of 75 patients, TNK was at least as safe as TPA. The next question you should ask yourself is TNK as effective as TPA? From data in that Phase 2b trial I just mentioned, the one by Parsons that was published in 2012, the co-primary efficacy endpoints selected by the investigators were clinical improvement at 24 hours using the NIH stroke scale score, and the volume of reperfused tissue using perfusion-weighted imaging on MRI 24 hours later. In patients who received either dose of TNK, 0.1 or 0.25 milligrams per kilogram, the average improvement in the stroke scale score at 24 hours was 8 points, versus only 3 points for those who received IV TPA, and this was hugely significant. Next, the percentage of reperfused brain tissue at 24 hours was 79% for TNK-treated patients, versus only 55% for TPA-treated patients, meaning that TNK saved a quarter more brain tissue from infarction versus TPA, also hugely significant. So there were obvious clinical and radiographic improvements in patients who received TNK at either 0.1 milligrams per kilogram or 0.25 milligrams per kilogram boluses. Additionally, over the long term, 90-day functional independence in these older patients who had a moderate to severe stroke was more often achieved in patients treated with TNK, 72% versus 44%, an absolute increase of almost 30%. And that's a pretty big difference in the proportion of patients who become functionally independent after 3 months. So the bottom line here is that TNK was not only as safe and effective as TPA, its efficacy was clearly superior to TPA in this small study. This investigation was followed by the ATTEST trial, whose results were published in Lancet Neurology in 2015. In this Phase 2 trial, Scottish patients were randomized to receive 0.25 milligrams per kilogram TNK or standard dose alteplase within 4.5 hours of stroke onset. Inclusion criteria for this trial were more generalizable. Basically, anybody with a good functional status who had new stroke symptoms within 4.5 hours and any points on the stroke scale score, not just moderate or severe strokes. There was no perfusion imaging or intracranial occlusion requirement, and patients could have had a prior stroke, unlike in the 2012 study. 104 patients were ultimately randomized to TNK or TPA in the ATTEST trial, and a stroke scale score of between 11 and 12. The ischemic core volumes on perfusion imaging were about 20 cc's in each arm, and penumbra volumes were about 40 to 50 cc's. About 3/4 of patients had an intracranial occlusion. So overall, the cohort included older patients with moderate strokes and moderate sizes for salvageable penumbra. The primary outcome was similar to that of Parsons' 2012 trial, percentage of reperfused penumbral tissue. And this was no different between groups, 68% for TPA and 68% for TNK. The average improvement in the stroke scale score was also no different between groups, 3 for TNK and 2 for TPA. You'll remember that TNK resulted in an NIH stroke scale score improvement of 8 points versus 3 points for TPA according to the Parsons trial, but we didn't see that same improvement in ATTEST. Instead, in the ATTEST cohort, a dramatic early neurologic improvement in 24 hours, meaning an improvement in the stroke scale score by 8 or more points, or a stroke scale score of 0 to 1 by 24 hours, slightly favored TNK over TPA, 40% versus 24%. And TNK was at least as safe, if not slightly safer for TPA for hemorrhagic complications and 90-day mortality. While the ATTEST trial was coming to a completion, the Norwegian tenecteplase stroke trial, NORTEST, began its own enrollment. NORTEST was a Phase 3 randomized clinical trial designed to determine efficacy of TNK over TPA in patients with acute stroke symptoms. And like ATTEST, which included patients with prior stroke and good premorbid function, modified Rankin scale score of 0 to 2, NORTEST also had broad inclusion criteria, and it included mild strokes. Lots of mild strokes. In fact, the median stroke scale score was only 4 for the entire cohort, which makes you wonder if a lot of those patients had strokes to begin with, or if there was a large degree of salvageable tissue, like we saw in Parsons' Phase 2 trial, which had 70 to 80 cc's on average there. In NORTEST, 1 in 8 patients had a large vessel occlusion, as opposed to 3 out of 4 patients in the ATTEST trial, and almost 20% of included patients were ultimately coded as stroke mimics. So not exactly a robust stroke cohort. But let's move on to the outcomes. The primary outcome of NORTEST was a 90-day modified Rankin scale score of 0 to 1, which was seen in 2/3 of patients irrespective of the treatment. Symptomatic ICH rates were low, about 2% per group, and 5% of patients died after 3 months. So what should we take away from NORTEST? Simply put, in patients with mild strokes and stroke mimics, TNK was associated with similarly low rates of bleeding and no clinically meaningful functional improvement over TPA. To determine a clinically meaningful difference, we would need a clinically meaningful stroke cohort, pure strokes with significant deficits and large volumes of hypoperfused tissue. Here's where we get to the Extend IA TNK trial, which was published on April 26, 2018, just a few weeks ago. Using the same doses as NORTEST and ATTEST, 0.25 mg per kilogram TNK versus standard dose alteplase, patients with acute ischemic stroke were randomized to one of 2 thrombolytic agents. Like patients from the earlier Parsons trial in 2012, Campbell and colleagues recruited patients with an acute intracranial large vessel occlusion who presented with 4.5 hours of symptom onset. Unlike prior studies, those with some functional disability, a premorbid MRS of 0 to 3, were included. All patients were anticipated to go for endovascular thrombectomy following systemic thrombolysis. Like the trials before it, this trial included a lot of older patients, with an average age being about 70, just like ATTEST and NORTEST and the Parsons trial. Patients had severe strokes, given the presence of an acute intracranial occlusion, with an average baseline stroke scale score of 17 for both groups, and the treatment arms were reasonably matched based on the location of the occlusion. 24% in each arm had an ICA terminus occlusion, 58 to 59% had an M1 occlusion, and 3% had basilar. The remainder had M2s. Ischemic core volumes were small on the perfusion-weighted imaging, about 10 to 15 cc's, whereas the penumbra volumes were incredibly large, 130 to 150 cc's of salvageable tissue for each group. Extend IA TNK was designed as a non-inferiority trial, and if TNK was found to be non-inferior to TPA, then statistical testing of superiority could be conducted. The primary outcome was reperfusion of at least 50% of the occluded vessel territory by the time of the initial angiographic assessment, which was about 40 minutes after initial treatment with TNK or TPA. This is equivalent to a TK2B or greater recanalization score. What the authors found was incredible. The recanalization rate of 10% in patients with a large vessel occlusion who received TPA grew to 22% if TNK was used. And after adjusting for the site of occlusion, TNK was associated with a more than 2-fold greater odds of TK2B recanalization by the time of angiography. Of all patients who had TK2B recanalization, 1 still underwent attempted thrombectomy. But by and large, this TK2B recanalization with TNK alone meant that patients did not need endovascular clot retrieval. Now, this sounds impressive, but you might wonder, what does this mean clinically for the patient? Everyone in this cohort was going for thrombectomy, regardless of the thrombolytic agent. And most people achieved a good thrombectomy outcome, a final TK2B or better for 80 to 85% of patients, despite whatever thrombolytic agent was used. No difference whether you got TNK or TPA. But I mentioned before that having to hang TPA versus push a bolus of TNK could cut down on transfer times and expedite additional stroke care. And maybe that has some clinical ramifications when it comes to thrombectomy. In the Extend IA TNK trial, there was a non-significant 10-minute delay between thrombolysis and arterial puncture for patients who were transferred from an outside hospital, and there was also a 5-minute delay for patients who were treated with thrombolysis at the endovascular site. If you look at the time from symptom onset to recanalization as a whole, treatment with TPA was associated with a nearly 30-minute delay, although this did not achieve statistical significance. Even so, time is tissue, and every minute lost may mean losing 1.9 million neurons. Clinically, can we say that the thrombolytic agent or this non-significant delay to recanalization makes any difference for the patient? I mean, we know that thrombectomy is overwhelmingly powerful at achieving recanalization, at reducing neurologic symptoms, and at facilitating functional recovery after stroke. Does it matter that you pre-treat with TNK over TPA? I guess the first thing we should do is ask whether TNK was at least as safe as TPA in this trial. It seems like it was. The rate of symptomatic ICH was no different between the two arms, 1% for both. The rate of any parenchymal hematoma was also similar, about 5%. Death, on the other hand, which you wouldn't expect to be different necessarily since the rates of recanalization following thrombectomy and the rates of intracerebral hemorrhage were not any different between the treatment groups. Death was different. Patients treated with TNK were at a non-significantly lower risk of death by 90 days than patients treated with TPA, 10% versus 18%. After adjustment, the p-value is 0.08. If you abide by the letter of the law, then yeah, the reduction in death due to TNK treatment means nothing. But if you look past it, that means that there's a 92% probability that this result wasn't found by chance alone. It's a real difference. So TNK seemed safe, but was it more effective? Radiographically, as I mentioned, we saw higher rates of recanalization before thrombectomy. But what does that mean? From a functional standpoint, the effect of thrombectomy was thought to be so powerful as to drown out any potential benefit over the pre-treatment thrombolytic agent. Surprisingly, the investigators found that this was not the case. There was a difference in functional outcomes based on treatment with TNK or TPA, regardless of the site of occlusion and irrespective of the fact that there was a high rate of recanalization with thrombectomy anyway. What the investigators found in this study was that there was a shift in 3-month disability that favored treatment with TNK over TPA, with a common odds ratio of 1.7, and yeah, here's your significant p-value of less than 0.05. This translates to a 70% chance that your 3-month modified Rankin scale score would be better if you received TNK over TPA. So what do I take away from this study? Is a new drug taking over acute treatment for ischemic stroke? Well, these results are quite promising, but we still have a ways to go. It seems that, at least for patients with moderate to severe strokes and large vessel occlusions, at least 2 trials have shown that TNK is superior to TPA in achieving good recanalization, and that this improves outcome, regardless of whether the patient is treated with mechanical thrombectomy. In patients with milder strokes, the superiority of TNK is less clear, but additional trials are needed. All that said, there is enormous practical benefit of TNK irrespective of any pharmacological or even clinical benefit, which the trials suggest. TNK can be given as a single bolus. For patients who are transferred for acute stroke management between hospitals, this may cut transfer delays tremendously. And I think that's one of the benefits that I'm hoping for when I treat my own future stroke patients. Maybe in the next few years, we'll see a shift in the way we manage acute ischemic strokes. Instead of the classic drip and ship, you might say that we push and pack up these patients for a more seamless inter-hospital transfer. Only time will tell, and I think for now, it has. That's it for our show this week. Thanks for tuning into the Brainwaves program. For additional information, I strongly encourage you to read the source material that was covered today, and you can find all the references to papers discussed here in the show notes. We didn't cover all the available data on TNK, just some of the high points, so be sure to check out this information on your own time. The Brainwaves podcast is recorded out of Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music for the program this week was courtesy of Hyson and John Watts. I'd like to thank all the clinician scientists, the investigators, the patients, and their families for participating in these clinical trials. Because of your help and your support, we are able to make an enormous difference in the lives of our patients. So thank you. And with that, I'm Jim Siegler. Thanks for listening.